The Foundation Fighting Blindness presents a Stargardt disease webinar, sponsored by Alkeus Pharmaceuticals.
Hello, everyone, and happy Saturday. Welcome to the Foundation Fighting Blindness Stargardt webinar that's sponsored by Alkeus Pharmaceuticals. My name is Bailey Bostelman, and I'm the Regional Field Director for the East here at the Foundation Fighting Blindness. And we're so excited to be with you all today, and we thank you so much for sharing your Saturday with us. So before we get things going, I would like to briefly review some logistical details for the call. Currently, all participant lines are muted. Today's call is being recorded and will be shared with all registrants after the meeting concludes. You'll also be able to find the recording on the Foundation Fighting Blindness website within the coming days. If you're using a screen reader, please be aware that the controls are at the bottom of the Zoom interface. This control bar may collapse when not in use, so please make sure to jiggle your mouse before clicking anything. If you prefer to prevent the controls from auto-hiding, go to your settings within the Zoom platform, select Accessibility, and then select Always Show Meeting Controls. If you have any questions throughout the presentation, please send them using the Q&A function within Zoom. Now, I would love to take a moment to introduce our amazing speaker today, Dr. Kenneth Fan, who joins us to discuss the latest Stargardt treatments, research, and progress that's being made in this space. Dr. Fan is a distinguished ophthalmologist who's based in Texas, specializing in inherited retinal disorders like Stargardt disease. Driven by the inspiring resilience of his patients, Dr. Fan is a dedicated clinician and researcher committed to advancing care and treatment for hereditary vision loss. He actively contributes to clinical trials for innovative drug development aimed at slowing or halting the disease progression, hoping that one day to translate these efforts into transformative treatments. Known for his compassionate approach, Dr. Fan is also a passionate advocate for patient education, effectively bridging the complexities of cutting-edge science with personalized care, making him a trusted leader in the retinal health space. As a reminder, throughout the presentation, feel free to drop your questions in the Q&A function because we will open it up at the end for Q&A if you have any questions for Dr. Fan. Now, I am pleased to go ahead and hand the floor over to Dr. Fan for our presentation today. Welcome, Dr. Fan. Thank you for joining us this Saturday.
Thank you so much, Bailey. It's a pleasure to be here and really glad to be able to share some of my thoughts and the things I've learned about Stargardt disease and just overall inherited retinal diseases in general. This is obviously a passion of mine that I care very much about, and I see many of these patients on a daily basis, I would say. So something that is very near and dear to my heart. I'm going to go ahead and share my screen. Yeah, so a little bit about myself. Bailey, you did a very overly gracious introduction for me already, but I am a vitreoretinal specialist, so I do medical and surgical retina. I see about 30% of my patients are inherited retinal disease patients, so patients with diseases like retinitis pigmentosa and Stargardt disease. I spend a fair amount of my practice doing research as well. So this is both sort of more basic research as well as clinical research, looking at drug development and helping patients find treatments that currently don't exist to help these treatments get FDA approved if they're safe and effective. I had my education done at Dartmouth College and Boston University School of Medicine, and my fellowship at Bascom Palmer, residency and fellowship at Bascom Palmer at the University of Miami. So it's been a long journey, but here I am at the Retina Consultants of Texas, which is a large group of retina specialists. I'm based out of Houston, Texas, and there's a lot of patients with Stargardt disease and inherited diseases of the retina in Houston and just in general in the South. So it's a big need, and I'm glad to fill that gap. So just to sort of dive into the presentation, I think what I'd like to do, especially when my target audience are patients and family members, just to give a sense of the differences between someone with an inherited disease of the retina like Stargardt and someone with a regular age-related retinal disease. So here on the slide, I'm showing two pictures of patients, two different patients. One is I'm calling Miss A, and Miss A happens to be a retired, healthy 60-year-old female, and she's getting a regular annual eye screen. And during this screening visit, the doctor notes, some changes on her retina exam, and she's diagnosed with age-related macular degeneration. Um, and then on the other side of the screen, we have Miss S. Miss S is a healthy, working 45-year-old female undergoing a regular eye exam. And the doctor also notes on Miss S's examination that there are some findings that are a little atypical, and she's also diagnosed with macular degeneration. Um, and over the next 5 to 10 years, Miss A has worsening eye disease. It seems to progress slowly, but luckily for Miss A, age-related macular degeneration has a lot of both approved and non-approved, but in development, drugs that work and work very well. And so if it's wet macular degeneration, there's therapies available for that. And if it's dry macular degeneration, as of 2 years ago, there's treatments for that as well. And so by age 70, Miss A is still seeing 20/20. She's still doing well. Of course, there's been some progression, but she's still functional and has good vision. On the flip side, Miss S, now who's on the screen, the AMD appears to be unusually aggressive. And over the next 5 to 10 years, Miss S finds that she's legally blind. And she's no longer able to drive or work and has to be fully dependent on her family members to take care of her. So this is probably a story that many of you are familiar with. Miss S is, of course, eventually diagnosed with Stargardt disease, which looks and acts very similar to age-related macular degeneration, but of course is not the same thing, and it tends to be more aggressive and start at an earlier age. As we all know, Stargardt disease has no treatment, and so it can be quite debilitating, especially in the working population. So before I get too technical, I'm going to kind of zoom out to the 10,000-foot view and talk about what the retina is in general. So on the slide here, I have a picture of an eyeball, which is more of a cross section, and the cross section is showing a an orange sort of what I call the wallpaper on the inside of the eyeball. So here you see the retina. And the retinal tissue is just like that. It's the wallpaper on the wall of the eye, on the inside of the eye. And the retina is the neural function of the eye that allows the eye to be able to process light and see, and it sends those signals back through the optic nerve to the brain. And if there's a problem with the retina, then you have a problem with your vision. So moving on to inherited retinal disease, which I call IRDs. IRDs are basically a group of inherited disorders that can cause different types of vision loss in all people. By definition, an inherited retinal disease is genetically passed down, so you have to acquire it. And well, I should say 99% of the time acquired from your parents. And sometimes it's a combination of both parents, and sometimes it's just one parent that gives it to you. And as I was saying before, there's a really wide range of symptomatic presentation. So what I mean by that is even within the same disease, you can get patients who present, let's say, more mildly, and there are patients who can present more severely. So the spectrum is very wide, and sometimes even the symptoms are very different in the same disease. So overall in IRDs, and Stargardt is one of these IRDs, there's 4 million people globally with an IRD. And we know as of now there's over 300 different genes that have been identified to cause an inherited retinal disease. And when we talk about a variable presentation, we call those phenotypes. And when we talk about the hundreds of genes that can cause a disease, we call that a genotype, the exact gene mutation. And both of these things can vary widely. So when I say the word or the group of diseases IRD, I'm talking primarily about retinitis pigmentosa, which is the most common IRD. It's 1 in 3,000. And Stargardt disease, which is close behind it in 1 in 5,000. And the estimates can range up to 1 in 5 to about 1 in 10,000. Then there's some other more rare diseases of the retina that can cause different types of presentation. One of these diseases is best vitelliform macular dystrophy. And there's another one called cone rod dystrophy. But for the focus of today, we will be talking about Stargardt disease. And looking at Stargardt disease specifically, it actually is caused by primarily a single gene, the ABCA4 gene, which you need both parents to pass a mutated copy of the ABCA4 gene to the patient in order to actually inherit the disease. And it is the most common genetic mutation in the world. On the screen here, I'm demonstrating two sort of cartoons, one of the visual cycle and one of a assembly line. And you don't obviously need to really understand the visual cycle here, but the general idea is that it is like an assembly line. The light comes in, it gets processed by different parts of the assembly line, which all have their own functions. And each one of these parts is essentially a protein in your retina. And if there's one part or one protein that is defective, that doesn't do its job, then the light doesn't get processed all the way through, and some of those byproducts of the light kind of break down and they build up, just like an assembly line. And in an assembly line, if products build up because one of those machines is broken, well, then you have a big problem and you're not able to really complete the job. And so this is true in the visual cycle. If there's really any defect at any point during the visual cycle, then you can end up with a big problem in your retina. So Stargardt disease, as I said before, it's about 1 in 5 to 10,000 people, about 30,000 patients in the United States with Stargardt disease, and about 1,000 to 1,500 new patients with Stargardt disease are diagnosed every year. We talked about the fact that it is caused by mutations in the ABCA4 gene, and most of the time, patients start with some blind spots in their vision, a little distorted vision, and general loss of central vision. Here I have a picture of the eyeball in the retina that I showed before, and I drew on here the area of the retina that tends to be affected by Stargardt disease. You see that black spot right there in the middle of the back of the eye, and that is what we call the macula. And so Stargardt disease is an inherited macular dystrophy because it affects the central vision, which is the macular portion of the retina. So now I show another picture of sort of like what appears to be a table, a party with, a bunch of snacks and fruits on the table. And this is courtesy of Johnson & Johnson, who has these depictions of what it's like to live with the disease. And this obviously is Stargardt disease. So in the mild form of Stargardt disease on the screen, you can see that there's a small, dim kind of gray spot in the central vision that distorts what you're looking at. In more moderate stage Stargardt disease, things kind of start to get blurred out a little. There's an obvious blind spot in the middle of the vision that distorts exactly what you're looking at. And then in severe stage Stargardt disease, pretty much most of that central vision kind of gets blurred out and distorted. And so it makes it hard to do anything with real accuracy with your fine vision. So many of my patients with Stargardt disease who have very severe Stargardt disease end up more like 2200 or 2400 vision, which tends to be legally blind. So we're going back to our patient now, which is Miss S. And Miss S is, of course, now living legally blind with Stargardt disease. And what does this kind of look like for her? Well, of course, she needs help getting to and from places. That includes her doctor. Family members have to take off a lot of time from work in order to take care of her and to drive her places. Of course, she herself is having a hard time maintaining a job because of the vision. And there's risk to overall physical health because, it's difficult to navigate. It can be hard to walk in certain places if the fine vision is not very good. And so there's heavy dependence on visual aids, low vision assistance. Even low vision specialists are an immense help because they have intimate knowledge of visual assisted devices. Okay, so now the question is, what are we doing about all of this and how can we help these patients? So the current state of disease treatment for Stargardt disease is mainly, I would say, mainly focused on targeted gene therapy. And what that means is looking specifically at the gene ABCA4 in order to treat that gene, replace that gene, and help that gene function again normally in the eye. Um, I'm only now looking at the question and answer. Sorry, someone had asked a question back it's just a minute ago. So what is the difference between Stargardt and rod cone dystrophy? That's a great question. Typically, when we talk about rod cone dystrophy, we're thinking about diseases that first affect the rods, which are the peripheral retinal cells, and the retinal cells that manage your night vision. And so these types of diseases include retinitis pigmentosa versus Stargardt disease, which is a disease of the macula. And so you end up affecting more of your daytime and central vision, and as a result, more of your cones. And so they're kind of like actually opposites. Rod cone is more peripheral, and Stargardt is more central. But that's a good question. It can be very confusing. Okay, so at this moment, the current state of gene therapy, or just really any therapy for Stargardt disease, is very, very promising, but there are it's difficult to get a treatment approved by the FDA. And so if you do a quick search, this was maybe a month or two ago that I did this. There's 12 active interventional trials for ABCA4 gene therapy. So this means that there's 12 clinical trials that are enrolling patients who have Stargardt disease, and they're getting actively treated by some sort of investigational therapy. And the number of FDA-approved therapies, of course, is zero. And so obviously there's a stark contrast between the number of drugs that are trying to be developed to help patients and the ones that are FDA approved. And we'll talk a little bit about why there's such a large disparity between the efforts to find treatment for Stargardt disease and actually getting something approved. This is probably my most complex slide of the presentation, and we don't need to fully understand the whole thing, but generally speaking, understand why Stargardt disease occurs is really important to understanding why it's so difficult to treat it. So in general, we talked about the visual cycle, and the ABCA4 protein is a very critical component of that visual cycle. It takes one of those parts and it kind of flips it over to the next portion of the visual cycle. And so if the part gets to the protein and the protein is broken and it is not able to flip it over to continue the assembly line, to continue the cycle, then it gets stuck there. And all of those things get stuck on that portion of the eye, and they build up into these things that we call lipofuscin. Lipofuscin is a bad thing in the retina because it builds up, and lipofuscin, when it builds up, it combines with each other and it causes these bad waste products that eventually irritate and can damage the eye. And so it's sort of like having a drain that's clogged and it's just building up and all this stuff is getting stuck there and you don't want it to be there. So back to sort of, you know, the major hurdles and why we have 12 and even maybe more now clinical trials underway for Stargardt, but zero approved. There's three major hurdles that I kind of want to talk about. The main one is, how do we really even get gene into the eye, into the retina to get it to start replicating and working? Back in 2017, the very first and still only approved gene therapy for an inherited retinal disease was discovered, and this drug is called Luxturna. And Luxturna treats a very, very rare form of eye disease caused by a gene called the RPE65 gene. And this defective gene, when someone is born with two defective RPE65 genes, these patients lose vision at a very early age. And Luxturna was basically discovered and had a way of delivering this RPE65 gene into the retina and allow it to work and work well, returning a lot of vision actually to these patients, which was an amazing, amazing feat and one of the probably the most important discoveries of retinal disease to date. But as you may realize, since 2017, nothing else has been discovered. And part of the challenge with ABCA4 is that the way when Luxturna was discovered and delivered into the retina, you cannot just package ABCA4 in the same way. It's too large. It's sort of like trying to put, you're like returning something to Amazon.com and you're trying to put a different thing into that box and it's just way too big to fit in there. And so in this case, ABCA4 does not fit in the same vector, in the same package as the Luxturna drug. So it doesn't work that way. So there are technological hurdles of thinking about, how you can deliver it. One of the ways to get through this hurdle, get over this hurdle, is to just cut the gene in half and deliver only half the gene. Well, my audience here must be thinking, well, if you only deliver half the gene, then you can only treat a portion of the patients because they have to have their problem in that half of the gene. And if they have a problem in the other half, then that treatment won't work. There's another way of potentially treating, and there are several companies doing this right now, which is cut the gene in half. So you have this cardboard box, and it's too big, right? So you cut it in half, and you get another box, and you deliver both of them in two boxes. And then once the boxes get into your retina, they recombine and become the full-length working gene. And this is a very novel and intriguing technology. To be perfectly frank, these companies are enrolling patients right now in clinical trials. And so we're super excited about companies that are doing this because it is truly a way to target the actual cause and the pathophysiology of the disease. And then instead of cutting the gene in half and delivering two halves of the gene, there's also just getting a bigger box, right? Finding a different way to put the gene into a bigger box and delivering that box into the retina. And that has not yet happened. I think people are still looking to see if there are ways to do that safely and effectively for patients. But the current technology is preferred because it was demonstrated safety in the Luxturna trials. And so people obviously firstly don't want to harm anybody. So if there's something that's safe, that's always the preferred mechanism. Okay, so that's hurdle number one, which is a lot. And I know, hopefully it's not too confusing the way I've described it. Hurdle number two is just how difficult it is to characterize the ABCA4 disease and the different ways that it affects patients. So ABCA4, we know, is the gene mutation. And let's say there's two patients who have mutations in the ABCA4 gene, and they both have Stargardt disease. Well, I have patients who come to me and they're 12 years old and they can't see in school because they can't read and they may never learn to drive, and their symptoms are very severe. And then I've got patients who come to me when they're 65 and they've been told they have macular degeneration. They still see well, they still drive, but they, lo and behold, also have Stargardt disease. So the heterogeneity, the variability of presentation of patients with this disease, with this mutation, makes it very hard for doctors to know who has what disease and how do we, measure them? How do we detect them and how do we test them and confirm that they actually have Stargardt disease? So, when there's a big range and a wide variety of patients, it makes it extra difficult. Okay, the last thing, which may or may not be actually the most challenging, is how do you go piggybacking off of problem number two is how do we actually measure these patients who have different presentations and different types of symptomatic onset and age of onset. So specifically, um, do we just test your central vision? Because, some patients with Stargardt disease might be able to read pretty well in the middle, but then everything just right next to it, sort of like a donut, is very blurry. And so it still makes it very difficult for them to let's say drive or to go from very bright to dark conditions or vice versa, from dark to light. So, do we test just your 20/20 vision? Is that even an accurate measurement of patients? Or do we check dark adaptation? Like how long does it take you to adapt to the dark when you go from light to dark? Well, some patients might not have a problem with that, and other patients may have a significant problem. Well, what about your field of vision? So let's say you struggle with just the donut space around your central vision. Do we check that? Or, some patients may not have a problem with that at all. What about reading in the dark? Is reading in the dark a problem? I would say a significant proportion of my patients have a hard time reading in the dark, but not all of them. So as you can see right now, it's extremely challenging. Right here on the bottom right of my slide, you can see what's called a low luminance maze. The low luminance maze test was used in the pivotal Luxturna trial to measure um, how well the drug was working in patients who were getting treated. And so um, this maze was how the FDA was really truly convinced that this drug was working. But in Stargardt disease, the maze is probably not the best way to measure patients because patients with Stargardt disease may not struggle as much with low luminance or dark conditions. And so navigating the maze wouldn't be as difficult for them. And they actually, after being treated, may not respond in the same way. So, what may work for one disease may not work for another. I'm seeing a question from A. Santos, comment on whether ABCA4 gene therapies under development are expected to be effective. Yes, this is a great question. This is, in fact, a very, very technical question that I will talk about in just a minute. I'm actually just getting there now. Okay, so back to the visual cycle, and I only show this slide because um, all of these. So what you see on the slide is the visual cycle and all of the proteins involved in it. But every single one of these steps where there's a light blue X demonstrates an area that's being targeted right now. So pretty much every part of the light cycle is being targeted by some company trying to find a way to slow disease progression or improve visual function in patients with Stargardt disease. Here you can see that there's people targeting the ABCA4 gene mutation, which we just talked about, people targeting uh, you know, proteins that recycle the waste from the buildup. Some people getting, reducing vitamin A buildup. Some people reducing lipofuscin buildup, which is, remember, when the toxic byproducts build up and they clump up and cause lipofuscin. So there's all sorts of you know approaches. Okay, so I find that when I talk to most of my patients, they are very well informed, and so they understand clinical trials and development. But I will just briefly go over this. So in when you talk about clinical trial development, usually you start with the preclinical phase, which is when you're in a lab and maybe you have animal models and you test whether these drugs even work at all. So you test it on the retina, you see if it actually improves the function of the retina or the protein actually works, and then you move, if it's effective, you move from the preclinical phase to the clinical phase, which is phase one. In phase one, you have a small number of patients that get tested. Basically, we call this first in human, and you have to make sure that it's actually safe. And then you have phase two, where you try to target the correct dose of the medication, so both safety and dosing. And when you talk about rare diseases, on the slide it says that phase one is 10 to 80 and phase two is 100 to 300. But in rare disease, then the numbers are much, much lower. Usually phase one and two are actually clumped together, and you're looking at maybe somewhere between perhaps 10 to 20 patients total. It can be, on either side of that number. Phase three is what we often call the pivotal trial, which is the trial that truly, once you've determined the right dose and you've determined that it's safe, you're looking at treating a large number of patients, so let's say 100 patients with Stargardt disease, to truly determine if it works. And usually in those clinical trials, you have to treat half of them and not treat the other half so that you have a comparison. Rarely you'll hear about phase four, which is just an extension trial looking at after it's been approved if it's safe or not. So so looking at the current developments for Stargardt disease, we have a number of treatments in phase one slash two. So we talked about those treatments that are looking at delivering the ABCA4 gene into the retina. We've talked about treatments like metformin. There's several oral therapies that are in phase two and three. These are treatments that try to reduce lipofuscin buildup and toxic byproduct buildup. There are some what I would call gene agnostic treatments to try to just overall improve the health of the retina. These gene agnostic treatments are both surgeries and injections in the eye. In general, what they aim to do is to reduce death of retinal cells or improve light activation and light transduction back to the brain. So these are all pretty progressed treatments in the clinical phase. Some of these treatments, the oral modified vitamin A is the Alkeus drug, which is the sponsor of this talk today. And Alkeus is it has some promising data in reducing the atrophy of Stargardt disease over time. And the other oral treatment is also a very promising treatment, which is a pill that you would take to reduce atrophy over time as well. So both of these drugs are very exciting sort of late phase clinical trials for patients with Stargardt disease. Now, the question that was asked earlier was about whether or not any of these therapies are under development may be used in atypical or mixed phenotypes. So I would say, by and large, almost all of these clinical trials are targeting Stargardt disease primarily. So, you're talking about the classic macular presentation, macular disease. Now, I will say, and I'll just fast forward a little bit here. This is a table at the end of my presentation that you guys can look at if you're curious about what's under development, both in the preclinical and the clinical phase. This table was compiled by one of my mentors, Nell Grigori at Bascom Palmer, who's an amazing surgeon and amazing clinician. MCO010 at the bottom here, second from the bottom, is it, recently had a clinical trial looking at what we call optogenetics, which is an injection of a light sensing molecule that helps patients with low vision to see more light in the areas where they weren't able to see before. And they did test this on patients with different phenotypes. So the macular phenotype, classic Stargardt, and also the more widespread rod cone phenotype. And it actually didn't work in the rod cone, as they call the pan-retinal phenotype. And so, this is technically it's just targeting, the disease, the ABCA4 disease in general. But I think in some of these clinical trials, you'll find that there just tends to be some patients that respond better to the treatment than others. But I will say most of these gene therapies are targeting patients who have classic Stargardt disease. Okay, so this is the first page of the table, and this is the second page of the table. You can see how many are just really being developed right now. So it's extremely exciting, and I'm glad to be a part of it. Um, I will say that this is the end of my presentation. I hope you guys really found that helpful to help you understand the disease itself and what it's like to live with the disease and what's sort of on the horizon for Stargardt disease. Thanks so much.
Wonderful. Thank you so much, Dr. Fan. I think this was a wonderful presentation and a lot of fantastic content. I noticed a few different questions coming through the chat. So if somebody was interested in becoming involved with one of these treatments within the clinical trials, how would they go about getting more information?
The cliche answer is to go to clinicaltrials.gov, but even for me, sometimes the website can be difficult to navigate because it's very technical. But there is every clinical trial that is active in the United States, and actually even beyond, has a contact email on clinicaltrials.gov. So if you've heard of a clinical trial and you search that trial on clinicaltrials.gov, you will find it. The other way to do it is to reach out directly to the Foundation Fighting Blindness, and if you have the contact name or email or even just know the company name of the clinical trial you're interested in, you could also email them directly because almost all of them have a patient outreach, section of their website. The last answer would be you could reach out to me. If you just look up Retina Consultants of Texas and my name, we have a phone number you can always call, and I'm happy to help patients, even if you don't live in Houston, Texas. We can always guide you in the right direction.
Wonderful. Thank you. And kind of around that same topic when it comes to clinical trials and the gene specific ones out there, does it make sense for anybody who's been clinically diagnosed with Stargardt's to go ahead and go through genetic testing so they can identify if they have the ABCA4 gene or one of the other various types of Stargardt before they go and start exploring these clinical trials?
Yeah, that is a fantastic question. It helps immensely for patients to have genetic testing already because most of these gene therapies are not, um, they don't target the overall disease if like you have just an overall retinal disease or a retinal problem. You have to have a gene specific disease. So even if you don't have genetic testing and you come to be involved in a clinical trial, we will have to genetically test you at that point. And if your test comes back as a different mutation, then you kind of have wasted your time a little bit, if you understand what I mean.
That's good to know. So these are definitely more of the gene specific treatments and clinical trials versus the gene agnostic.
Right.
I will say for anyone who is listening on the call today that if you have been clinically diagnosed and have not been genetically tested, at the foundation, we do offer a no-cost genetic testing program so that you can get that testing done. And then we will have a genetic counselor who will go through those results with you. So if you are interested and that's something that you haven't done yet, feel free to reach out to us and we can get you connected. So another question came in here with some of these clinical trials is, what to consider before enrolling. Are there risks? If you do one clinical trial, does that take you out of the running for any future clinical trials? What does that look like?
Every clinical trial involves risks, and I'm very upfront and frank with my patients about this, because every patient has to understand the risks and the benefits of every trial. And it's probably maybe one of the most important things are the risks involved in early phase clinical trials. Um, and the risks vary from treatment to treatment. If you're taking, let's say, a pill, that tends to be a little less invasive. But at the same time, pills are systemic. So, it can affect other parts of your body, let's say your kidneys or your liver or your blood. Um, but you're not getting, let's say, a surgery in your eye. So if you're getting a surgery in your eye, surgeries are more invasive. You have to go under anesthesia. There could be risk of retinal detachment or infection in your eye, pain in the eye. But at the same time, you don't have to worry so much about liver function and stuff like that. So it's very trial specific, I will say.
Okay, perfect. Good to know. And there are a few questions in here about who to contact at the foundation about clinical trials or how to go through the genetic testing. If you reach out to us it's info@fightingblindness.org, we can get you directed in the right place to get all of that information over to you. So there also is a question in here from an individual who lives in South Africa but does not have access to any clinical trials. Is there any consideration for patients who maybe are not located here in the US?
Yeah, so some of these trials actually are global. I know that uh, some of those oral pill trials, like even Alkeus, I think, is looking to have a global presence soon. But many of these companies will also help support patients to even fly to the areas where patients are getting treated for the clinical trial. So that's, for example, I'm in Houston, but I've had a patient fly over to me from Italy, for example, and have some of that cost reimbursed by the company. So um, that's not a blanket case, but I do think that it does happen. And so the goal would be to contact the company to see if that's even a possibility, or the site.
We're going to switch gears just a little bit here and talk more about the patient education and intervention. So we have an individual in here who's curious about those who maybe are addressing some of those mental well-being or dealing with the diagnosis. What are some of the resources that can help people now while they wait for some of these clinical trials and therapies to be moved forward?
This is obviously a subject of much discussion at every single one of my patient encounters, because obviously there's nothing approved right now. Um, Primarily speaking, your best friend will be a low vision specialist who is a master of assisted vision devices to help you stay independent and navigate. Some of my patients with Stargardt disease have learned how to use bioptic glasses to help them drive. So before they weren't driving, and now they can drive with bioptics. So regaining some of their independence in that regard. So I think, reaching out to vision specialists who focus on patients with hereditary retinal diseases is probably your best bet.
Thank you so much. And I will say that at the foundation, we are happy to connect you with some of those local resources as well. So if you do want to reach out to us, we're more than happy to connect you with other organizations that maybe cover more of that everyday living aspect. We also have a partnership with Alma, where we are working with them to educate the therapists that work with the Alma organization on low vision. So if you do have any mental health needs, we have resources available. And I will actually go ahead and drop that link in the chat for anybody as well, just in case they would want to check out those resources. So we have a couple other questions here. And this one might be a little bit more of a difficult one to answer just because science takes time and there's a lot of processes before things actually hit the market and get that FDA approval. But what could individuals expect for the timeline of some of these therapies that maybe are in the phase 1, 2, or the ones that have or that one that has been entered into that phase 3?
Yeah, I think once a company is in a phase 3, the question is, how long is the study and how quickly can that study get enrolled? So in the current phase 3, I know that they're still enrolling. And usually and the FDA is motivated for rare diseases to fast track these treatments. So it is better than other types of clinical trials. But I will say overall, it's probably 2 to 3 years before we have some promising data on the efficacy of a phase 3 and then approval maybe shortly thereafter. But of course, if the data doesn't pan out like we want it to, and things are slightly disappointing, then it could be back to the drawing board. So it's hard to say.
Great, thank you. Yes, I think that's the challenging part with a lot of these therapies is there's a lot of checks and balances along the way to make sure it is safe for the patients. So putting an end date on those timelines is a little bit challenging.
Yeah.
So we have one more question here, and I think we'll go ahead and get ready to wrap up for today's session. But we have an individual who has been impacted by the macula and peripheral vision. And is this the rod cone phenotype you referred to in the therapies described? Would they help somebody who is impacted by these both phenotypes?
Without looking at your eye myself, it'd be hard to know if it's truly rod cone or if it's just a very broad, severe form of Stargardt disease. If it's just sort of a more severe form of Stargardt disease, I do believe a lot of these therapies would still be available to you. But if it's truly more of a retinitis pigmentosa or a rod cone phenotype, it could be a little more challenging and less effective.
Thank you for that. And if there were any questions or comments that were not answered on today's call, we will do our best to answer them afterwards as well. If you have any thoughts that come up afterwards, feel free to send them over to us at our email address, which is info@fightingblindness.org. But once again, Dr. Fan, thank you so much for spending your Saturday with us. This was fantastic content. I think that, there was so much covered today. So I know that there may be some follow-up questions. So I'm sure we can go ahead and send those to you afterwards and get the answers back over to our friends here that joined us. Once again, we appreciate all of you who joined us today for this webinar. Thank you again for Alkeus Pharmaceuticals who made today happen. Be on the lookout because we will have more of these coming up in the following month, covering various topics around Stargardt disease. So we hope you'll be able to join us again. Once again, thanks, Dr. Fan. Thanks everyone else for joining us and have a great rest of your weekend.
Thanks for having me.
Bye, everyone. Thank you.
Thank you for joining the Foundation Fighting Blindness Stargardt Disease webinar, sponsored by Alkeus Pharmaceuticals.